When you really look at the statistics, it's kind of staggering.
Hmm.
We're talking about, what, 11.3% of the U.S. population dealing with this chronic condition, diabetes.
It is, and it's often working away quietly.
Mhm.
Its impact isn't just about blood sugar. It really reaches into almost every part of the body,
Yeah, it can touch virtually every system.
which makes managing it effectively, well, it's complex, but absolutely crucial in healthcare today.
Exactly. And that's why today we're really diving deep into the core concepts around caring for people with diabetes mellitus
Mm,
DM.
yeah.
We've pulled together insights from some pretty detailed nursing and medical sources,
Mm.
the kind that, really get down to the nitty-gritty.
Yeah, the goal here is to sort of unpack the essentials, what you really need to grasp to understand this condition.
We want to zero in on why managing blood glucose, that glucose regulation piece, is just so central, and frankly, how many different things you have to think about when it comes to care.
It's definitely multifaceted.
So we're going to cover quite a bit. From the basic biology, what's supposed to happen versus what goes wrong, all the way to handling, acute emergencies and trying to prevent that long-term damage.
And we'll touch on some things that might surprise you, like why foot care is so incredibly important and how these different medications actually work. It's quite fascinating.
Okay, so let's start right at the beginning. Diabetes mellitus. What is it, fundamentally?
Well, at its heart, it's a really common chronic condition, and it affects the body's ability to either produce or effectively use the hormone insulin.
Okay.
And that impairs glucose regulation. Now, it does affect how the body handles all nutrients, carbs, proteins, fats. But the main issue, the sort of primary concept we focus on, is that impaired glucose regulation.
Right, glucose regulation meaning basically keeping blood sugar levels in the optimal range.
Exactly. And our sources really hammer this home. When that regulation is off, it's the root cause, the spark for so many problems, both acute crises and those chronic issues that, unfortunately, can shorten lifespan.
Okay, so let's break down how that regulation is supposed to work. Where does it happen?
A lot of the control comes from the pancreas, specifically the endocrine part of the pancreas. It's interesting. It has two jobs, exocrine for digestion and endocrine for glucose.
And that endocrine part has specific cells.
Yeah, tiny clusters called the islets of Langerhans. Inside those, you've got different cell types. Key ones are the alpha cells, which make glucagon, and the beta cells, which make insulin and another hormone called amylin.
Insulin and glucagon, those are the big players, right? The main dancers in keeping blood sugar balanced.
They really are. Think of insulin like a key. It gets released, especially after you eat.
Right.
And its job is to unlock receptors on your cell membranes. That allows glucose, the sugar from your food floating in your blood, to actually get inside the cells.
Where it's used for energy or stored.
Precisely. And insulin release is clever. There's a sort of low, steady background level called basal secretion, and then a big burst right after meals, the prandial release.
Okay, so insulin lets sugar in. What about glucagon?
Glucagon is the counterbalance. It works the other way. When your blood sugar starts to drop too low, glucagon sends a signal, mostly to the liver,
Telling it what?
telling it to release stored glucose back into the blood. It kicks off processes called glycogenolysis, breaking down stored glycogen, and gluconeogenesis, making new glucose. Basically
so-
says, hey, need more sugar out here.
Got it. So they work together to keep things stable. Are there other hormones involved?
Yep, there are others called counter-regulatory hormones, things like epinephrine, norepinephrine, growth hormone, cortisol. They also tend to raise blood sugar, working against insulin when needed, like during stress or fasting.
So the fundamental problem in diabetes, whether it's not enough insulin or the insulin isn't working right, the issue is that glucose can't get into the cells properly.
That's the core of it. You can have plenty of sugar circulating in the blood, hyperglycemia, but the cells themselves are effectively starving for energy.
Even though the fuel's right there.
Exactly. And when that happens, the body gets desperate. It starts breaking down other things for energy. It breaks down fat, that's lipolysis, and it breaks down protein, proteolysis.
Okay.
This releases free fatty acids and amino acids into the blood, which adds to the metabolic chaos. It contributes to the high blood sugar, and importantly, the breakdown of fat can lead to acidic byproducts called ketone bodies.
Ah, okay. So it's not just high sugar, it's the body's reaction to the cells not getting that sugar that causes other problems too, like those ketones.
Precisely. It's a whole cascade of events stemming from that initial problem with insulin.
Okay, that makes sense. Now, our sources talk about different types of diabetes. How does this core problem show up differently?
Well, the two main categories are type 1 and type 2 diabetes.
Right.
Type 1 is much less common. You often see it diagnosed in younger people, though it can happen at any age. It's an autoimmune condition.
Meaning the body attacks itself.
Yeah, the immune system mistakenly targets and destroys those beta cells in the pancreas, the insulin factories. So the end result is little to absolutely no insulin production.
So the body literally destroys its own ability to make the key. And you said it's often abrupt.
Yes, the onset can be quite sudden. Symptoms can develop quickly once enough beta cells are gone.
Okay, that's type 1. What about type 2? That's the more common one.
Much more common. Accounts for maybe 90–95% of adult diabetes cases.
Yeah.
And it's usually a progressive condition. It often starts differently than type 1.
How so?
It typically begins with insulin resistance. The locks on the cell doors, those receptors, they become less sensitive to the insulin key. The key is there, maybe even lots of it initially, but it doesn't work as well to let the glucose in.
So the locks get sticky, basically.
That's a good way to put it. And the pancreas tries to compensate. It pumps out more and more insulin to try and overcome that resistance. This state is called hyperinsulinemia.
But it can't keep that up forever.
No. Over time, those hardworking beta cells can start to get exhausted, and eventually insulin production begins to decline. So you end up with both resistance and reduced production.
And this one's linked more to lifestyle and genetics.
It's multifactorial, yeah. Genetics play a role, but factors like obesity, physical inactivity, age, and having metabolic syndrome significantly increase the risk. And unlike type 1, it often develops gradually, sometimes over many years, often without obvious symptoms at first.
But, and this seems important, regardless of how it starts, type 1 or type 2, the end result of that impaired glucose regulation, it leads to similar long-term damage.
That's a crucial point. Chronic high blood sugar, that hyperglycemia, damages organs and tissues over time, no matter the type of diabetes.
Okay, so let's talk about those consequences. We mentioned high blood sugar, hyperglycemia. What are the classic signs that things are off?
When blood sugar gets really high, the kidneys go into overdrive trying to filter it out. But there's a limit to how much glucose they can reabsorb back into the body. So excess glucose spills into the urine, and water follows sugar osmotically. This leads to polyuria, having to pee a lot, large volumes.
Which would make you dehydrated.
Exactly. That fluid loss triggers intense thirst polydipsia. You feel constantly thirsty.
Okay, polyuria, polydipsia. What's the third P?
Polyphagia, excessive hunger. Even though there's tons of sugar in the blood, remember, it's not getting into the cells efficiently. So the cells are sending starvation signals to the brain.
Wow. So you're peeing constantly, incredibly thirsty, and starving hungry, all because the sugar can't get where it needs to go.
Those are the classic triad. And you also mentioned weight changes earlier.
Yeah, especially in type 1, right?
Yes. Particularly before diagnosis, that abrupt weight loss is common in type 1 because with no insulin, the body is just aggressively breaking down fat and muscle tissue for any energy it can get.
Makes sense. Now, beyond those immediate symptoms, you said high sugar damages blood vessels. That leads to poor tissue perfusion.
It does. Think of chronic hyperglycemia as making the blood thicker, maybe stickier, and directly damaging the lining of blood vessels. Both the big ones, the arteries, that's microvascular damage, and the tiny ones, the capillaries, microvascular damage.
And damaged vessels mean less blood flow.
Right. Reduced blood flow means less oxygen and fewer nutrients getting delivered to tissues throughout the body. This is a huge reason why people with diabetes often have problems with wound healing. A small cut might take much longer to heal, and the risk of infection is higher.
Okay, so that's the chronic, slow damage. But you mentioned earlier that sometimes things go wrong acutely, those glucose-related emergencies.
Yes, there are three main ones that are critical to recognize because they require emergency treatment. They are diabetic ketoacidosis, or DKA,
Okay.
hyperglycemic hyperosmolar state, or HHS,
HHS.
and the opposite problem, hypoglycemia, or low blood sugar.
Let's take DKA first. You said that's more common in type 1?
Often seen in type 1, yes, but it can occur in type 2, especially during times of severe stress, like a bad infection. DKA is caused by a profound lack of insulin.
Okay.
This leads to very high blood sugar, but also remember those ketone bodies from fat breakdown?
Yeah, the acidic ones.
In DKA, because there's so little insulin, fat breakdown goes into overdrive, and you get a massive production of these ketones. They're acidic, and they build up in the blood faster than the body can buffer them.
Leading to metabolic acidosis.
Yeah.
Acid in the blood.
Precisely. So you have the high sugar symptoms, thirst, urination, maybe hunger, dehydration, weight loss. But plus the effects of the acidosis, nausea, vomiting, abdominal pain are common.
And that breathing thing, Kussmaul breathing.
Yes, that's a key sign. Deep, rapid, almost gasping breaths. It's the body's desperate attempt to blow off carbon dioxide, which is an acid, to try and compensate for the metabolic acidosis. And people in DKA often have a characteristic fruity or acetone-like smell on their breath from the ketones.
Wow. And it can affect mental status, too.
Definitely. From alert but ill all the way to stupor or coma. It also causes significant dehydration, electrolyte imbalances, especially potassium shifts, and overall tissue hypoxia. It's a true medical emergency.
Okay, that's DKA, high sugar plus acid. How is HHS different? You said that's more common in type 2, especially older adults.
Correct. HHS is mainly characterized by extremely high blood glucose levels, often way higher than typically seen in DKA, like over 600 milli-GDL, sometimes over 1,000.
Whoa.
And severe dehydration, leading to very concentrated blood-high osmolarity. The key difference is that in HHS, there's usually just enough insulin still trickling out to prevent that massive ketone production and severe acidosis that defines DKA.
So incredibly high sugar, extreme dehydration, but generally no major acid problem.
That's the main distinction, yes. Because the acidosis isn't the driving feature, the symptoms are often dominated by the severe dehydration and the hyperosmolarity's effect on the brain. Neurologic symptoms are very common and can be profound confusion, drowsiness, seizures, even temporary paralysis.
And does it come on as fast as DKA?
Usually HHS develops more slowly, sometimes over days or even weeks, often triggered by an underlying illness or infection that increases dehydration and stress hormones.
Okay, so DKA and HHS are both high sugar emergencies, but with key differences. What about the third one, hypoglycemia, going low?
Right. Hypoglycemia is when blood glucose drops below the normal range, technically below 70 milli-GDL, but symptoms often kick in more noticeably around 50 or 60, though it varies.
And what causes that? Too much insulin.
That's a big one. Taking too much insulin or certain oral diabetes medications that stimulate insulin release. Also, skipping meals or snacks, exercising more intensely or longer than planned without adjusting food or meds, drinking alcohol, especially on an empty stomach. Kidney failure can also contribute, as it affects how insulin is cleared.
You mentioned our sources say it's better to be a bit high than too low. Why is low sugar so dangerous so quickly?
Because your brain runs almost entirely on glucose. It needs a constant supply. When blood sugar plummets, the brain is starved of its primary fuel.
And that causes...
That causes neuroglycopenic symptoms, the direct effects of the brain lacking glucose. Things like fatigue, weakness, dizziness, difficulty thinking or concentrating, confusion, slurred speech. If it's severe and prolonged, it can lead to seizures, loss of consciousness, permanent brain damage, and even death.
That's incredibly serious. What about the symptoms people usually think of, like feeling shaky or sweaty?
Those are the adrenergic symptoms. They're caused by the body's stress response releasing hormones like adrenaline when blood sugar drops. That causes the shakiness, nervousness, heart pounding, sweating, intense hunger, sometimes tingling.
So the body tries to warn you.
It does, but here's a critical point. Some people, especially those who've had diabetes for a long time or older adults, can develop hypoglycemia unawareness. They lose the ability to feel those early warning signs.
Which sounds really dangerous.
It is, because they might not realize their sugar is dangerously low until they're already confused or pass out. It significantly increases the risk of severe episodes and things like falls.
Okay, wow. So those are the big three acute emergencies. DKA, HHS, and hypo. Scary stuff. But let's shift back to the long term. Those chronic complications you mentioned earlier from the slow damage over time.
Right. This is where consistent, good glucose control really pays off down the road. Chronic hyperglycemia, day in and day out, damages blood vessels and nerves, leading to these long-term problems.
You mentioned macrovascular, the big vessels. What's that look like?
Primarily, it means a massively increased risk of cardiovascular disease, CVD. Diabetes is considered a major independent risk factor for heart attacks, strokes, and peripheral vascular disease, or PVD, poor circulation, especially in the legs and feet.
And that risk gets worse with other common issues, like high blood pressure or cholesterol.
Absolutely. Things like smoking, inactivity, obesity, hypertension, high cholesterol, they all compound the risk. That's why managing those factors aggressively is a huge part of diabetes care.
Using medications like statins for cholesterol or ACE inhibitors for blood pressure.
Exactly. Drugs like atorvastatin, a statin, are very common, and ACE inhibitors like lisinopril are frequently used not just for blood pressure, but because they also offer some protection to the kidneys, which we'll get to.
Okay, so that's the big vessels. What about the microvascular complications, the tiny ones?
This is where we see damage to the eyes, kidneys, and nerves.
Let's start with the eyes. Retinopathy.
Diabetic retinopathy, yes. It's damage to the tiny blood vessels in the retina, the light-sensitive tissue at the back of the eye. It's actually a leading cause of new blindness in working-age adults.
How does it cause blindness?
The damaged vessels can leak fluid or blood. In a more advanced stage called proliferative retinopathy, the eye tries to grow new, fragile blood vessels, but these can bleed easily into the eye, block vision, or cause retinal detachment.
So regular eye checkups are vital.
Absolutely critical. Annual dilated eye exams are recommended to catch changes early when treatment is most effective.
Okay, eyes. What about kidneys? Nephropathy.
Diabetic nephropathy. Again, damage to tiny blood vessels, this time the filtering units in the kidneys, the glomeruli. Diabetes is the #1 cause of end-stage kidney disease, ESKD, requiring dialysis or a transplant.
How does the damage happen there?
Chronic high blood sugar and high blood pressure essentially scar those delicate filters. One of the earliest signs is protein, specifically albumin, leaking into the urine called albuminuria or microalbuminuria.
So testing urine for protein is important.
Yes, annual screening for albuminuria is standard care. And again, controlling blood pressure is key, often using those ACE inhibitors or similar drugs called ARBs, as they have a protective effect on the kidneys beyond just lowering blood pressure. And it's worth noting, some diabetes meds, like metformin, need to be used cautiously or avoided if kidney disease becomes significant.
Good point. Okay, eyes, kidneys. What about nerves? Neuropathy.
Diabetic neuropathy is nerve damage caused by high blood sugar. It can affect different types of nerves.
Like in the feet.
Peripheral neuropathy is very common. It often starts in the feet and legs, working its way up. It can cause sensations like numbness, tingling, burning, or sharp pains. But crucially, it can also cause a loss of sensation.
Meaning you wouldn't feel an injury.
Exactly. You could step on something sharp, get a blister from your shoe, or have a small cut and not even realize it because the protective sensation of pain is gone. This ties directly into foot problems.
We'll come back to feet. What other nerves can be affected?
Autonomic neuropathy affects the nerves that control involuntary bodily functions. This can lead to a whole range of issues. Gastroparesis, for example, is delayed stomach emptying, which messes with digestion and blood sugar control. Orthostatic hypotension causes dizziness when standing up. Sexual dysfunction is also common.
Wow, it really could affect almost anything. Now let's circle back to the feet. You teased this earlier. Why are foot complications such a big deal?
It's really that dangerous combination: neuropathy, loss of sensation, poor circulation, peripheral vascular disease, and often impaired wound healing and immune function.
The perfect storm.
It really is. A person might not feel a minor injury. Poor blood flow means the tissues don't get enough oxygen or nutrients to heal properly. And high blood sugar can impair the immune response. So a tiny blister or cut can rapidly progress to a non-healing ulcer.
Which you get infected.
Easily. And infections can spread to deeper tissues, even bone. This can lead to tissue death, gangrene, and ultimately is a major reason for lower limb amputations in people with diabetes. There's also a specific deformity called Charcot foot, where the bones weaken and collapse, leading to a rocker bottom shape, very high risk for ulcers.
So foot care isn't just about hygiene, it's about active prevention and surveillance.
Absolutely. Daily self-checks of the feet, wearing proper fitting shoes, never going barefoot, getting regular foot exams by a healthcare provider, and prompt treatment of any minor issue are paramount.
Got it. One last chronic complication mentioned was cognitive dysfunction.
Yes, research shows an increased risk of cognitive decline and dementia, particularly in older adults with diabetes. It's thought to be related, at least in part, to that same microvascular damage affecting blood flow and cells in the brain over time.
Okay, so the complications are widespread and serious. This really underscores the need for diagnosis and ongoing monitoring. How is diabetes actually diagnosed?
There are a few standard blood tests used for diagnosis based on glucose levels.
What are the main ones?
Probably the most common is the hemoglobin A1C test, or just A1C.
Oh, right. That's the average sugar over time.
Exactly. It measures the percentage of your hemoglobin, the protein, in red blood cells that has glucose attached to it. Since red blood cells live for about 3 months, the A1C gives a good picture of your average blood sugar control over the previous 2 to 3 months, maybe even 4, according to some sources.
And what level diagnoses diabetes?
An A1C level of 6.5% or higher on 2 separate occasions is generally diagnostic criteria. For managing diabetes, the goal for most people is usually an A1C below 7%, though targets can be individualized.
Okay, so A1C gives the average. What about checking sugar at a specific point in time?
That's where the plasma glucose tests come in. A fasting plasma glucose, or FPG, measures blood sugar after you haven't eaten for at least 8 hours. A level of 120 milli-GDL or higher is diagnostic.
All right.
Then there's the oral glucose tolerance test, the OGTT. This is used less often for routine diagnosis, more commonly for gestational diabetes during pregnancy. You drink a standard glucose solution and your blood sugar is checked 2 hours later. A level of 200 milli-GDL or higher indicates diabetes.
And sometimes just a random check.
Yes, if someone has classic symptoms of high blood sugar, like that excessive thirst and urination, a random plasma glucose test taken any time regardless of meals, showing a level of 200 milli-GDL or higher can also be diagnostic.
Once someone is diagnosed, monitoring becomes key for management, right? Like finger stick testing.
Absolutely. Self-monitoring of blood glucose, or BGM, using a glucometer and finger sticks is crucial for many people, especially those on insulin. It provides immediate feedback on how food, activity, stress, and medication are affecting blood sugar levels in real time.
And patients need to learn how to do it properly.
Yes, education on proper technique, when to test, how to interpret the numbers, how to calibrate the meter, and even how to store test strips is really important for getting accurate results and using them effectively for self-management decisions.
And now there's also continuous glucose monitoring, CGM.
Yes, CGM technology has advanced significantly. It uses a tiny sensor inserted just under the skin, usually on the arm or abdomen, that measures glucose levels in the interstitial fluid, the fluid between cells, every 1 to 5 minutes.
Wow, constantly.
Pretty much, yeah. It sends the readings wirelessly to a reader, smartphone, or insulin pump. It provides a much more complete picture than finger sticks alone. You see trends, patterns, time spent in range, and it can provide alerts for high or low glucose levels, even predictive alerts sometimes.
Yep. That sounds incredibly useful for fine-tuning management.
It really can be, especially for people on intensive insulin therapy or those with hypoglycemia unawareness. It gives so much more data to work with.
Okay, so bringing this all together, diagnosis, monitoring. What are the main strategies for actually managing diabetes day to day?
The overall goal, really, is collaborative care between the patient and the healthcare team. The aim is to promote optimal glucose regulation to prevent those acute emergencies and delay or prevent the long-term complications we talked about.
It starts with lifestyle, I assume.
Absolutely foundational. Medical nutrition therapy, or MNT, is key. This usually involves working with a registered dietitian nutritionist, an RDN.
What does that involve?
It's about developing a personalized eating plan, focusing on balanced meals, portion control, understanding carbohydrate counting if needed, limiting saturated and trans fats, cholesterol, and added sugars. It's not about a single diabetes diet, but tailoring it to the individual's needs, preferences, and lifestyle.
Makes sense. And exercise.
Physical activity is huge. The general recommendation is at least 150 minutes per week of moderate intensity aerobic activity, like brisk walking, spread over at least 3 to 5 days. Plus, adding resistance exercise, like lifting weights or using bands, twice a week is also recommended.
How does exercise help specifically?
It helps improve the body's sensitivity to insulin, helps with weight management, lowers blood pressure and cholesterol, reduces cardiovascular risk. Lots of benefits for glucose control and overall health.
And weight management itself is important, especially for type 2.
Definitely. Even modest weight loss, say 5–10% of body weight, can significantly improve blood sugar control, blood pressure, and lipid levels in people with type 2 diabetes who are overweight or obese. Some medications, like metformin, can sometimes help with weight management too.
Okay, so nutrition, activity, weight. What about medications? There seems to be a lot now.
There are many different classes of non-insulin medications available, primarily for type 2 diabetes, and often combination therapy using drugs from different classes is needed to reach glucose targets.
How do doctors choose which ones?
It depends on many factors. The individual's A1C level, how long they've had diabetes, other health conditions they have, like heart or kidney disease, potential side effects, cost, and patient preferences. Interestingly, many newer drugs not only lower glucose, but also have proven benefits in protecting the heart and kidneys.
Can you give a quick overview of some major types, like metformin?
Sure. Metformin is typically the first-line drug for type 2. It mainly works by reducing the amount of glucose produced by the liver and slightly improving insulin sensitivity.
Okay.
Then you have classes like sulfonylureas, which stimulate the pancreas to release more insulin. DPP-4 inhibitors, sometimes called gliptins, work by enhancing the action of natural gut hormones called incretins, which helps insulin release and reduces glucagon.
What about those injectable ones you hear about, like Ozempic?
Right, those are GLP-1 receptor agonists or incretin mimetics. They mimic those gut hormones, leading to increased insulin secretion, suppressed glucagon, slowed stomach emptying, which helps with feeling full and often promote weight loss. They're injectables, usually once weekly or daily.
And you mentioned ones that make you pee out sugar.
Yeah, those are the SGLT2 inhibitors, the FLAZNs. They block the reabsorption of glucose in the kidneys, so excess sugar is excreted in the urine. These have shown significant heart and kidney protective benefits, too.
Fascinating mechanisms. Are there important things to watch out for with these drugs?
Definitely. For example, metformin shouldn't be used in severe kidney disease and usually needs to be held before procedures involving high-V contrast dye due to a rare risk of lactic acidosis. Sulfonylureas carry a risk of hypoglycemia and shouldn't be used if someone has a sulfa allergy. The injectables like GLP-1 agonists and another called pramlintide, an amylin analog, can cause GI side effects like nausea. It's crucial patients understand the specific instructions and potential side effects for their medications.
And then, of course, there's insulin therapy itself, essential for type 1, often needed for type 2 eventually.
Correct. Insulin is the mainstay for type 1 and becomes necessary for many with type 2 as their disease progresses and their own insulin production declines.
And there are different kinds of insulin.
Yes, lots of different types, categorized mainly by their onset, how fast they start working, peak, when they work strongest, and duration, how long they last. You have rapid-acting, taken right before meals, short-acting, taken a bit before meals, intermediate-acting, and long-acting or ultra-long-acting insulins that provide a steady background level, that basal coverage, often taken once a day.
How do people usually take insulin?
Most commonly via subcutaneous injection just under the skin. Patients need thorough education on proper injection technique.
Like where to inject?
Right. Rotating injection sites is important. Common areas are the abdomen, back of the upper arms, thighs, and buttocks. Rotating helps ensure consistent absorption and prevents developing lumps or dents in the skin called lipodystrophy. Also, understanding the angle of injection, proper storage insulin needs refrigeration before opening, but the vial or pen currently in use can usually be kept at room temperature for a month or so.
And using pens versus vials.
Insulin pens have become very popular. They combine the insulin cartridge and injection device, making it often easier and more discreet than drawing up insulin from a vial with a syringe. But both methods are used. And it's critical to remember, insulin is designated as a high-alert medication.
Meaning errors can cause serious harm.
Exactly. An overdose can cause severe hypoglycemia, and underdosing can lead to hyperglycemia and DKA. Double checks and careful patient education are vital.
What about insulin pumps?
Insulin pumps are small computerized devices that deliver a continuous infusion of rapid-acting insulin through a thin tube called a cannula inserted under the skin. They provide a basal rate 20/47 and allow the user to deliver bolus doses for meals or corrections.
Can they automate things?
Some pumps can integrate with CGM systems. These are sometimes called hybrid closed-loop or artificial pancreas systems. They can automatically adjust the basal insulin delivery based on the CGM readings, helping to prevent highs and lows. They still require user input for meals, but offer a higher level of automation and potentially tighter control. But pumps require significant training and commitment.
And very occasionally, surgery. Pancreas transplant.
Yes. For a select group of patients, usually those with type 1 diabetes who also have end-stage kidney disease and are getting a kidney transplant, a pancreas transplant, either whole or just the islet cells, can be an option.
Does it cure the diabetes?
A successful transplant can restore normal insulin production and glucose regulation, making the person insulin independent. However, it's major surgery and requires taking lifelong immunosuppressive drugs to prevent rejection, which have their own risks and side effects. But graft survival rates are actually pretty good.
Okay, let's quickly revisit those acute emergencies. If someone does have hypoglycemia, what's the immediate treatment?
If the person is conscious and able to swallow, the standard advice is the rule of 15.
Rule of 15.
Give 15 grams of a fast-acting carbohydrate. That could be 3 to 4 glucose tablets, about half a cup, 4 ounces of fruit juice or regular soda, a tablespoon of sugar or honey, or 5-6 hard candies.
Okay. 15 grams of fast sugar. Then what?
Wait 15 minutes, then recheck the blood glucose. If it's still below 70 milli-GDL, repeat the 15 grams of carbs. Once the glucose is back above 70, it's a good idea to have a small snack containing protein and carbs if the next meal is more than an hour away to prevent it from dropping again.
What if they're unconscious or can't swallow?
That's a medical emergency. Someone trained should administer injectable glucagon, which triggers the liver to release glucose. Or, in a hospital setting, IV dextrose would be given. It's also why people at risk for severe hypo should carry glucagon and wear medical identification.
Right, and for DKA or HHS?
Those require immediate hospitalization, often in an intensive care unit. The top priorities are aggressive intravenous fluid replacement to combat the severe dehydration, especially in HHS, followed by an IV insulin infusion to gradually lower blood sugar levels, and very careful monitoring and replacement of electrolytes, particularly potassium, as insulin drives potassium into cells, potentially causing low blood levels. And of course, treating the underlying cause, like an infection.
And for managing at home, our sources mentioned sick day rules. Why are those so important?
Because illness, even something simple like a cold or flu, can wreak havoc on blood sugar control. Stress hormones released during illness tend to raise glucose levels.
So what are the key rules?
First, don't stop taking diabetes medications, especially insulin, unless specifically told to by a doctor. In fact, insulin doses often need to be increased during illness. Second, monitor blood glucose frequently, maybe every 2 to 4 hours. Third, if you take insulin, especially type 1, check for ketones in the urine or blood regularly. Fourth, stay hydrated, sip fluids like water, broth, or sugar-free drinks constantly. If you can't eat solid food, try to consume liquids containing carbohydrates.
And know when to call for help.
Absolutely. Call your doctor or diabetes educator if you have persistent vomiting or diarrhea for more than, say, 6 hours, a high fever, moderate to large ketones, symptoms of DKA or HHS, or if the illness lasts more than a day or two without improvement. Having a sick day plan in advance is really crucial.
It really sounds like so much of successful diabetes management comes down to the patient themselves.
It absolutely does. Patient education and promoting effective self-management behaviors are arguably the most critical components of diabetes care. It's a condition that requires daily attention and decision-making by the person living with it.
So what does that education need to cover? It seems like a lot.
It is comprehensive. It includes understanding the basic disease process, the purpose, action, timing, dosage, and side effects of their specific medications, how and when to monitor blood glucose and ketones if needed, how to interpret those results and make adjustments.
Plus complication prevention.
Yes, strategies to prevent complications, especially that essential basic foot care, daily inspection, proper nail care, appropriate footwear. Also, recognizing the signs and symptoms of both high and low blood sugar and knowing how to treat them appropriately, and those sick day rules we just talked about.
It's about empowering patients, really.
Exactly. It's moving beyond just giving information to actually building skills, confidence, self-efficacy, and problem-solving abilities. We often talk about initial survival skills education needed right at diagnosis versus more in-depth, ongoing education for comprehensive self-management.
Because ultimately, the patient and their family are managing this 24/7.
Precisely. The healthcare team provides guidance, support, and adjustments, but the day-to-day reality, assessing how they feel, monitoring, choosing food, managing activity, taking medications correctly, checking feet, identifying problems early, that all falls to the individual living with diabetes.
Wow. We have definitely covered a huge amount of ground today.
We really have. We've gone from the fundamental biology of how glucose is supposed to be regulated to exploring how that system breaks down in type 1 and type 2 diabetes.
Right, and the consequences, those acute crises like DKA, HHS, hypoglycemia, and the really serious long-term damage to eyes, kidneys, nerves, heart, and feet.
We look at how it's diagnosed and monitored using tools like A1C, finger sticks, and CGM, and then delved into the management strategies, the crucial role of lifestyle, the array of medications including different types of insulin and non-insulin drugs, pumps, and even transplants in some cases.
And throughout, the absolute necessity of patient education and self-management really came through.
I think the big takeaway is this. Diabetes is complex, it's chronic, it demands constant attention. But, and this is a big but, understanding that core concept of glucose regulation and actively participating in proactive, comprehensive care makes a world of difference.
It can genuinely change the course of the disease.
Dramatically, it can significantly improve day-to-day quality of life and, critically, prevent or significantly delay those severe life-altering complications.
So whether you're listening to understand your own health better, or maybe you're supporting a friend or family member, or even learning for professional reasons, hopefully this deep dive into the dynamics of glucose regulation provides a really helpful framework for understanding this incredibly common condition.
Yeah, and perhaps it leaves us with something to think about. Given just how much daily self-management burden falls on the individual, the constant monitoring, calculations, choices, what are the biggest systemic barriers or support challenges people face in actually achieving that optimal care? And how can recognizing those challenges help us create better support systems and ultimately lead to better outcomes for the millions living with diabetes every day?
That's a really important question to carry forward. Well, that wraps up this deep dive. We really hope you feel better equipped now to navigate the complexities of diabetes mellitus. Join us next time as we explore another topic in detail.